welcome to the Cross-Setting Quality Improvement Strategies for MSPB conference call. My name is Christine, and I will be the operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. During the question-and-answer session, if you have a question, please press star then 1 on your touch-tone phone. I will now turn the call over to Ms. Sarah Brinkman. You may begin.
Thanks, Christine. Hello, everyone, and welcome to our webinar, Cross-Setting Quality Improvement Strategies for MSPB. This is the final in our 3-part webinar series focused on Medicare Spending for Beneficiary, and we're so glad that you've joined us today. My name is Sarah Brinkman, and I'm a Program Manager for the Lake Superior Quality Innovation Network, which serves healthcare providers in Minnesota, Wisconsin, and Michigan. Before we jump in, let's address a few housekeeping items. Those of you who registered before today should have received a reminder this morning, which included a link to the webinar event page, where you can find the handouts for today's presentation, and Gerald Ann Shields will be posting that link in chat as well. A recording of today's webinar will be made available in a couple of weeks, and you'll be able to find a direct link to that recording from the event page. We encourage you to ask questions throughout the presentation utilizing the chat function, and we'll be asking you shortly to share in chat in response to a question that we'll be posing to you as well. We will address your questions at the end and open up the lines for folks to share other strategies and initiatives that they're undertaking with regards to MSPB and to pose any questions they might have at that time over the phone. Finally, when you close out of today's webinar, we'll be automatically redirected to a short evaluation, and we greatly appreciate you taking a few minutes to provide us with feedback. We'll use that feedback to inform the remainder of our webinar series for this work, and as well as future educational offerings. Upon completing the evaluation, you'll receive a certificate of attendance for your records. As was mentioned, this is the final in a 3-part webinar series focused on Medicare spending per beneficiary. During the first webinar, we laid the groundwork for understanding the measure. On the second webinar, we dug into regional data analysis to identify some of the most frequent drivers of MSPB in order to understand what hospitals and healthcare systems could focus on to improve performance. Information about the first 2 webinars, including links to the handouts and recordings, are available in today's slide deck, and they'll be posted in the chat as well. Today, we'll be focusing on how the factors that influence MSPB affect and are affected by other settings of care, and hear promising practices for improving performance on the measure. We hope to leave ample time at the end of the call for participants to share their thoughts as well. We're going to start with a short refresher on what was covered in the last 2 webinars, but first we want to hear from all of you and are asking you to share in chat. Has your facility implemented any strategies aimed at improving your MSPB score? I realize this is a yes or no question, but if your answer is yes, please provide us some examples. And if your answer is no, please let us know why that's the case. If you haven't endeavored to address the MSPB score, why have you held back? And if you have been looking at your MSPB score, what kinds of initiatives have you tried to undertake? We're just going to give folks a couple minutes here to share in the chat. We do hope that this will be an interactive session. We all learn more when we share together, so please don't be shy. I know that you're all typing away vigorously. I want to make sure that I give you ample time to respond before moving on too far into the content. But in the interest of time, I am going to keep moving forward just with a reminder that what we're going to cover first is a refresher from the last 2 webinars. So if you were participating in those, this should be a refresher. So going back to the first webinar, we started by answering the question, what is MSPB? The Medicare Spending per Beneficiary measure allows us to evaluate hospital efficiency relative to other hospitals as it relates to spending on Medicare fee-for-service patients. For MSPB, lower scores are better, indicating greater efficiency, and this measure is currently the sole measure making up the efficiency and cost reduction domain of the hospital value-based purchasing program, thereby affecting Medicare fee-for-service payments to hospitals participating in the value-based purchasing program. So let's take just a couple of minutes to ground ourselves in the MSPB measure methodology by reviewing the MSPB timeline, which you can see here. This slide shows you the full timeline, and over the next few slides, we'll break it down by its parts. So when we talk about an MSPB episode, it begins with an admission of a Medicare fee-for-service beneficiary to an acute care hospital. The time from admission to discharge is referred to as the index admission. And the MSPB episode begins with any Medicare fee-for-service claims made during the 3 days prior to the index admission and extends to any claims that start within the 30 days following discharge. An important distinction here is that a claim may start anytime during that 30 days and extend beyond that time frame. So, for example, if a patient is admitted to a skilled nursing facility 29 days post-discharge, the entire Medicare fee-for-service claim for that SNF stay would be counted toward the episode spending for MSPB, even though service dates may be well beyond the 30 days post-discharge. So what you see here represents the actual spending that is measured for MSPB. That's 3 days prior to the index admission and claims started within 30 days post-discharge. There are a number of factors that are considered in terms of risk adjustment for the final measure, including any hierarchical condition categories that are coded in the 90 days leading up to the beginning of the episode. In other words, 93 days prior to the index admission. The HDCDs, or hierarchical condition categories, and other risk factors such as age, end-stage renal disease status, and so on may drive the expected spending for a particular beneficiary higher, therefore providing the hospital a bit of wiggle room, if you will, as it relates to the final calculation of MSPB. If you'd like more detailed information about how MSPB is calculated, we really encourage you to check out Webinar 1 from this series, but we also wanted to pause here to see if there are any questions. So if you have questions, please post them in the chat, or Christine, if you could provide the instructions for how to queue up over the phone.
Thank you. We will now begin the question-and-answer session. If you have a question, please press star then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. There will be a delay before the first question is announced. If you are using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star then 1 on your touch-tone phone. Once again, if you have a question, please press star then 1 on your touch-tone phone.
Thanks, Christine. So then we wanted to open it up for questions for anyone who has any questions about how MSPB is calculated, recognizing that that foundational understanding is really important before we can dig into what can you do to improve the measure. Not hearing any questions at this time. There will be opportunities for questions later on, and you can always post in chat. But now I'm going to turn things over to my colleague, Eric, who is going to walk us through a brief overview of the regional data analysis we reviewed during the second webinar. So as a reminder, our focus in this analysis was on the 3 state regions served by the Lake Superior Quality Innovation Network, which includes Michigan, Wisconsin, and Minnesota. One last thing before I turn things over to Eric. I know that it can be confusing when we're talking about quality data, and it's important to orient ourselves to the time period being discussed. So the majority of the data presented today reflects MSPB performance from calendar year 2016, which was provided in the 2017 hospital-specific reports for MSPB and will impact payment in fiscal year 2018. Eric?
Okay, well, thank you, Sarah. So I'm going to just go over a few of the slides that, as Sarah said, we went through on our previous webinar. And we will start with the big picture here, and that is looking at the actual MSPB scores on average for the 3 states that are in our region here. And what we have here is the scores from the 2015 data. Those are in the dark blue, And then we have the 2016 scores in the gray. And you can see we are comparing these both for Minnesota, Michigan, and Wisconsin. And we have the national average rate for 2016 in the red line. And so what we are seeing is that all three of our states have scores in 2015 and 16 that are below that or better than the national score. And we saw that Minnesota and Wisconsin both had a slight increase in their score from 2015 to 2016, while Michigan had a slight decrease. And so to break this down a little bit further, here we are looking at the percent of the episode spending that is happening in those different time periods that Sarah already talked about. On the left-hand side is the percent of the episode spending that is happening in that pre-index time period. The middle section is the spending that is happening in the during that index hospital stay, and then the far right side has the spending that's happening in that 30 days post-index stay. So as expected, we're seeing that a very small percent of the spending is actually happening in those 3 days prior, with the biggest amount of cost happening during the actual index hospital stay, with still a substantial amount of spending that's also happening in that post-index time. And a few things that we saw with these data here, if you look at Michigan in that light blue, we saw that they had a little bit lower percent of spending in the during the index time period, but a little bit higher percent spending in the post-index time. And that could be compared with Minnesota, that's in the darker blue, where the percent spending was a little higher in the during index, but a little lower in the post-index. And we saw that Wisconsin, that's shown in the red bars, had kind of a spending that's in between. And so to break it down even farther, what we did is look at those same time periods, the pre-index, during, and post, and break it down. On the bottom, you can see there's those 7 different claim types that we talked about. The home health, hospice, inpatient, outpatient, the skilled nursing, the durable medical, and the carrier. And this just breaks it further down to see where the percent spending is happening among those claim types in each of those times. And so, as expected, the during index time in the center, we're seeing the bulk of the spending is falling into that inpatient, with a certain amount in the carrier file, which is basically for the physicians and other providers who bill separately. It's actually in the post-index time that we kind of see some more interesting things, and where we can see that the costs are spread out among all the different types, with the highest amount in the post-index inpatient and skilled nursing, with a little bit smaller amount in the home health, and outpatient. And so this table here is really looking at the same exact data that we were just seeing, but just put it in table format to look a little more closely at that post-index time. And so, as we said, Michigan had a little bit lower spending in the during index time, that second row across, but a little bit higher spending in the post-index. And so we can kind of break that down by those different claim types in that post-index time here and see that it looks like that's happening in the home health, the inpatient, and the skilled nursing. Whereas you look at the next column over, that Minnesota had slightly lower spending in those types. And if you look at that row that's a little bit further down there, the length of index stay, we just wanted to look at how long is that index hospital stay. So we saw that Michigan had an average of 4.47, Minnesota was 4.55, and Wisconsin was 4.29. So we're seeing that Minnesota actually had the longest index stay, but this is not, what we're seeing is not correlating with a higher MSPB score, actually. If you look at the bottom row, we're showing what each state's average MSPB score was. We're seeing that Minnesota had the lowest score. Another interesting finding, we saw that Minnesota, even though it had the lowest MSPB score, did not actually have the lowest spending per episode. In fact, it was the second highest. So that must mean, if you look back at what we talked about in the first presentation, is that the risk adjustment process is then indicating that Minnesota must have patients that are coming up with a higher expected cost. So that is why, even though those hierarchical condition categories that are used for the expected cost aren't occurring in claims that are during the episode, they can have a significant effect on your score. And so here we're just making a few more points about the HDCDs, and these are 70 different indicators that are taken from the claims that the patients have during that period 90 days before the start of this episode. And these are used in combination with the end-stage renal disease indicator and the disability indicator and age to basically determine what that person's episode is expected to have for spending. And I should mention that the model also does include some interaction terms for the interaction between those HDCs and the other status fields, because researchers have found that a certain type of comorbidities can increase costs in a greater way depending on that person's other statuses.
Great. Thank you, Eric. So just some high-level lessons we took from the regional data analysis. They included recognizing the impact of care provided post-index charge, the importance of finding a balance between the cost of index care and post-index care, The need for consistent and complete ambulatory care documentation as the hierarchical condition categories are a major player in risk adjustment. And maybe most importantly, that there is a lot more analysis to be done to understand factors at play not only for our region, but for your individual facilities. And some of those ideas that we thought would be interesting to look into as far as data analysis included further analysis of the hierarchical condition categories with particular interest in the impact of comorbidities, identifying any relationships between readmissions and index costs, similarly identifying any relationships between post-acute care and index costs, and in both of these working to find that sweet spot, always with a focus on improving patient outcomes but driving efficiencies as well. Analyzing the most costly diagnosis-related groups, or DRGs, during each period, so pre, during, and post-index. Analyzing the most costly and most frequent DRGs by digging into their related ICD-10 codes. And finally, we thought it would be interesting to consider the linking the data to a facility's electronic health record in order to assist in assessing severity. So, in other words, does this data align with what you expect based on the data you have in your EHR? I want to pause here to see if there are any questions or suggestions of other things to consider with regards to either our lessons learned or the possibilities that exist for further data analysis related to MSPB. And for now, if you have any of those thoughts, if you could share them in chat or jot them down so you remember them when we open up the lines at the end of the call. So now that we have a shared foundational understanding of MSPB, we want to consider some of the quality improvement strategies you might employ to improve your performance. As the last half hour and the previous two webinars have demonstrated, MSPB is highly complex. One of the goals of this webinar is to highlight the interconnections between settings of care and how these settings affect and are affected by the factors contributing to a hospital's MSPB measure. So going back to our timeline, we can see that in the center we have the care provided at the hospital during the index admission. Afterwards, we have the care provided in a variety of settings, including skilled nursing, primary or specialty care, home health, possibly readmissions to the hospital, and so on. And prior to the admission, we've talked about the importance not only of that care provided in the 3 days before the index, but also the documentation used to capture those hierarchical condition categories that factor into risk adjustment. In this way, we can see that we can see the ways that other settings of care have an impact on the factors that inform the MSPB measure, and this highlights the importance of cross-setting collaboration on the part of hospitals that are looking to improve their efficiency. Let's twist that slightly to help underscore that this collaboration across care settings is mutually beneficial. So we know that hospitals have a stake in this. From a quality reporting program perspective, we obviously are talking about the MSPB measure under value-based purchasing, but there's also a clear tie to the readmissions reduction program, noting that readmissions are a major driver for your MSPB score. If we consider skilled nursing facilities, they have a newly launched value-based purchasing program whose current sole measure is focused on readmissions. And we also know that there's a newly developed MSPB post-acute care measure that's being discussed. Finally, in the ambulatory setting, we know that the cost category for the Merit-Based Incentive Payment System, or MIPS, under the Quality Payment Program, QPP, is expected to go into effect starting with calendar year 2019, and that's also looking at costs across settings of care. And so while we know that everyone has a vested interest in improving their efficiencies and their patient outcomes just from a basic business perspective, these programs are all aligning towards and highlighting that CMS is looking at alignment across settings of care to achieve that efficiency portion of the triple aim. Before we open up the lines to hear from all of you, we're going to turn things over to Bonnie Friedenberg and Hannah Lashala from Douglas County Hospital in Alexandria, Minnesota. They'll share a bit about their hospital's MSPB journey and some of the strategies they believe have had a role in play in improving their MSPB score. I want to note that with the examples from Douglas County Hospital and any of the sharing we hear from others on the call, We know that MSPB is highly complex, and it's incredibly difficult to say definitively that a particular initiative or action on the part of a hospital or health system is the cause of a change in your MSPB score. That said, we're hopeful that through sharing and continued analysis, we can help one another figure out how to impact this measure, ultimately improving care to patients and decreasing healthcare costs in the process. So, Bonnie and Heather, I'll turn things over to you.
Hi, thanks for having us. You want to go to the next slide. And it's Hannah with me. So the first year in 2012 is the first time that I reported on this measure in my quality role. I can honestly say I did not completely understand this measure, but knew that it was a good thing that we were below that 1.0 statistic. In 2011, so that was that first 2012 year, our average spending for Medicare patients was $17,200. At that time, we were above the state, but we were below the United States, so we did not take any action. Then the next year, we were at 0.94. Again, this was reported. We didn't take any other specific action. Then in 2014 and 15, we were at 0.96, kind of, hoping at that point that we weren't seeing any kind of a trend. 4 trending points isn't enough to draw a conclusion on that. But as you can see, in 2016, we were at 0.98, which that was reported at many of our physician meetings with administration, and that's when we started to implement more of our action plans, which I'll get to in a minute. And then you can see in 2017, we had a significant drop to 0.88. So on to the next slide. I have some of our spending comparison data. What I do not have included on this slide is 2014. In that year, our average spending was $21,200. If you remember, back in 2011, we were at $17,200. So in that 3-year timeline, we had increased our spending by $4,000 per beneficiary. In this 2015 year, which is included on this bar graph, our spending was at $20,100, and we were above the state, which is in the red, and similar to the United States in spending. And then that's where you can see our drop then going forward to the 2016, where we were at $17,900. So only about $500 more than where we were sitting in 2011. Then on to some of our action plans. One of the things we did is in January 2016, we sent 2 of our nurses for 2 weeks of training in clinical documentation. We knew we wanted to make that as a goal to improve documentation. Also, we recognize that there can be better reimbursement for this, but ultimately wanted to reflect our patients' acuity accurately. We did have administrative support of this program, and our chief medical officer was definitely behind this as well. We reported at some of our physician meetings. We would have quality indicators for our physicians. It's somewhat of an incentive that they work with our CDI staff for response rate and agree rate. This is something that we report on. Initially, we did monthly, and then we now it's closer to quarterly report. The physicians have done very well and work very well with our CDI staff, but I really believe that has to do with that administrative support of that. Initially, we did very well with the program. We did see an increase in our case mix index. Then for future quarters, it did decrease somewhat. we needed to regroup on the program and really hone in to really following those Medicare patients so that we would be always looking at least 90% of the Medicare patients. And in addition, we did ICU patients. Excuse me. Essentia was very gracious and allowed us to do a site visit for our CDI program. Excuse me, we went to Fargo. And so we developed a better understanding of risk of mortality and severity of illness. I guess I just would give an example. If we would have a patient that had multiple comorbidities and had a hip fracture, if there would be a mortality, we wouldn't want to see them with a risk of mortality of 2 and a severity of illness of 2, but rather, again, accurately reflecting on the acuity of that patient. We also learned that mortality reviews can be done even after discharge. So, for example, our CDI staff does not work on weekends. If there was a mortality, we can still work with that hospitalist group to support that documentation and really we're striving to get the risk of mortality and severity of illness, closer to that 3 out of 3 or even 4 out of 4 in those cases. And then Hannah's going to talk a little bit about strategic pricing.
So from the finance, can you go back, Sarah, one? Thank you. From the financing perspective or from the finance rev cycle perspective, all of those things that Bonnie and Quality and the CDI team are working on, they directly impact your reimbursement, but in a way that that affects that risk-adjusted score. So you want all that comorbidities, and you want to report the true acuity of that case because that reflects of how sick that patient is, which then obviously will lead down to the post-30-day care they receive, whether it's SNF-related, Bonnie will talk about that in a few minutes, or the additional clinical care they can receive in an outpatient, less expensive setting. So I put strategic pricing on here, and now that's not specific Medicare related, but a lot of the things we're doing in finance and the rev cycle perspective is focusing on some of that. Are you capturing what your contracts truly say? Are you holding them accountable? Are you looking at your service lines that you're offering when they're post-admission? Are you keeping those services in-house as much as you can because that's where you can control those costs? Kind of trying to work with some of the clinics and sharing that quality data too in that post-30 day time frame. And as a reminder, Douglas County Hospital does have a multi-specialty clinic that we have access to. That's part of our organization. So again, keeping those costs internal to try and help control that, but truly capturing and holding accountable what's on your contracts as it relates to the acuity levels that are listed by the quality team. So I'll turn back to
on to the next slide. So one thing we really knew we needed to look at is decreasing our utilization of skilled nursing facilities as a first option post-discharge. This especially is true within our joint camp patients. One of the problems that we were seeing is the care was so good at our skilled nursing facilities. They had a great program for rehab that patients would prearrange rooms. I would call it reserve a room before they have their total joint replaced, and then they would tell their friends. So when their friends came in to have a joint replaced, they expected that as almost the standard. Some of this has self-corrected with as we decrease our length of stay, but I'll get to that in just a minute. But just no longer being able to automatically need a 3-night qualifying stay. So on this slide, you can see in 2015 and even prior years, we were sitting at about that 22.8% utilization, which we were significantly higher than the state and the U.S. In 2016, that was a significant drop for us. As you can see, we're still higher than state and United States. Then I'll go on to decreasing length of stay. For joint camp, that's one of our bigger surgical procedures that we do at our facility. I don't have included here, but in 2014 we were at 2.8 for length of stay, so then 2.6, and we decreased that to 2.45. We know we have a ways to go, but it is improving in small increments year to year. Overall Medicare length of stay, 3.9 down to 3.6. All of these changes may seem small other than use of skilled nursing facility, but together these improvements, I think, have significantly impacted our Medicare spending per beneficiary.
So beyond the technical, kind of the things that we think have allowed us to make an impact on our Medicare spending per beneficiary, the other things we have started and will continue to do is talking about these things at multidisciplinary teams. And we just included a list of those multidisciplinary teams, which is physicians, nursing, organizational leaders, meaning SLT, and operation leaders, finance, and rev cycle. Each of these, understanding that each of these facets of an organization truly impact that cost. So, and it's not just the quality, it's not just the clinical component. So being transparent with our data, talking about it, making people comfortable talking about it, even though sometimes we all don't understand it, or a change can make us rethink it. Incorporating, multidisciplinary teams to have those discussions is something we have been doing and will continue to do.
One other thing I don't have on this slide for future plans, but we just sent 3 staff from our Alexandria clinic to outpatient clinical documentation improvement conference, and that was just this week. So I know that we are definitely exploring adding an outpatient CDI program. Just one last thing in support of that CDI program, because we knew we had so much to learn, and we've always been involved in a utilization review regional meeting, but we decided to start our own regional CDI. We do it biannual at our facility, and that's just a good way for us to network and learn from others, because we don't pretend to have all the answers at this point. And we're having a good turnout at that, so that's been kind of exciting for us, and we have that coming up now in October. We just hosted right here at our hospital, provide lunch, and it's a good time for us to just talk amongst a team. And finance staff is also included in that, finance and coding, so we do try to work pretty closely together, all of our entities.
So with that, Sarah, we'll turn it back to you.
Thank you so much, and I'm sorry, Hannah, that I called you Heather. Apologies. As soon as I said it, I realized I did it. Okay. Thank you both so much for that. I know that I have a few questions, but before I jump in with questions, I want to encourage folks to type in the chat. And Christine, if you could provide instructions again on how to get queued up on the phone.
Yes, once again, if you'd like to ask questions, please press star then 1 on your touch-tone phone.
Great. So as we're waiting for other folks to weigh in, I was wondering if either of you could speak a little bit more about what you believe you can attribute the decrease in the skilled nursing facility stays to. I know you said that there's been a decrease, but it sounds like there's great care being provided, and that word of mouth can sometimes be a tough thing to address. You certainly don't want to drive away folks from great services. So what can you attribute that decrease to?
So specifically with our orthopedics, we have an ortho team meeting. Our orthopedic surgeons also attend that, and it was bringing this data, showing them, especially like the Medicare Spending report, we would show them that that's only an annual report. But then we started keeping track. We had a more detailed report that we could run out of our Epic EMR that we looked at use of skilled nursing facility by what type of surgery. So whether it was total shoulders, total joints, or spine, we also looked at different spine fusions, but just different patient groups, and we were able to kind of focus on those. And then we were starting to see a decreased utilization, but we also involved nursing leadership, administrative staff, of course, and the other thing I think that was very important, our joint camp coordinator, physical therapy, and social services, because what social services was finding out when they would first do their initial interview with the patient, they already had these plans. And so it was really all of us joining forces to set the expectation of, well, I'll just use a total knee for an example, that, you know, the expectation is that you will be doing great and you're going to be going home in 2 days. You know, and we know there'll be some that could stay longer, and, you know, we're working towards achieving that goal. So it really was all of us together. So I hope that answered your question.
Yeah, that's great. Thank you. Christine, do we have anyone on the phone?
We have no questions at this time.
Thank you. I do have another question for you all before I kind of open up the lines and ask for a few others to share their examples. So one thing that we found in digging into MSPB is that we weren't sure who to reach out to when it came time to promote these webinars and any resources that we were developing around MSPB, because it's kind of unique to some of the quality measures, particularly its counterparts in the value-based purchasing program, in terms of the fact that it is really a financially based measure in that sense. And so just wondering if you can share from your experience working in quality and in finance, if there are other examples of ways that you've worked together in the past on these types of related measures, or if MSPB is unique in that way, and any lessons learned from that kind of cross-departmental collaboration.
We're both thinking.
As long as I say, you know, that silence, you're not sure.
And hopefully, this is Hannah. Hopefully I can answer your question. Removing the silos and allowing these departments to work together, you know, as we talk more about value-based purchasing and some of the contracting arrangements that go with that, quality and finance, you know, we partner more on those things because of the overlap of the components of those contracts. You know, some of those payments are based on quality measures, so having them at the table and talking about those things and what's achievable, as well as like overall shift in patient care. So as we move from, you know, inpatient to hospital, more outpatient services, outpatient meaning ancillary, hospital ancillary and clinic, you know, it's trending, some of that stuff. So those are kind of some of the projects we've been partnering on, which, you know, I always like to say although they're separate, you know, if you say MSPB is separate, then value-based purchasing, and then ACO, CIN, they're all somewhat intermixed. They all impact each other somewhere along the way. So making sure we were using these interdisciplinary teams, whether we're talking about MSPB or other initiatives, they all will somehow directly impact your next initiative.
And I would add to that is Hannah has a revenue cycle team meeting monthly where she has invited quality staff to, you know, be an active participant in that meeting. I think that's kind of helped quite a bit. So we just get more comfortable with each other and the type of work that we do and the things that we're both looking at. So I'm sure we each have different focuses, but yet really the big picture is all the same.
Great, thank you. Appreciate those insights. We did get one question in chat for you all, and I think, Bonnie, you mentioned you're looking at the CDI project for outpatient. So the question is, how different is outpatient CDI from inpatient CDI? Is the skill set different, or is the level of coding as specific as inpatient?
Well, I would be able to answer this question a whole lot more once I can meet with our team when they get back. I think they probably just get back tomorrow. If I'm not mistaken, it was Monday, Tuesday, Wednesday. And then, what we're doing, I know it's not exactly answering your question, but we're having them come to be now part of our CDI coding team meetings, and then our regional meetings, we're going to ask them to present to our regional group their learnings. So I'm going to learn with them. I wouldn't be able to answer all the differences. I know that our CDI specialists, as we've gotten more comfortable with the inpatient part, it seems like it's just pushing us to do more and start looking at what's happening in that time period before they come into the hospital, so the documentation piece.
Great. Well, we look forward to hearing from you and some of the insights that you've learned. I know you and I chatted before the call about the potential impact of a CDI initiative in the outpatient setting on capturing those hierarchical condition categories and what you might see for MSPB in that way. Wonderful. Well, thank you both very much, and we hope you'll stay on the line in case there are additional questions. We do have a couple of other hospitals that have offered to share with us some of the things that they're doing around MSPB, and we'd like to encourage anyone else on the line who is interested in sharing. We'd love to hear from you. We learn more when you share with us. So I'm just going to call on a couple people. So if Andy from St. Elizabeth Hospital, if you could press *1 to get queued up to share on the line. Andy is with St. Elizabeth Hospital in Wisconsin, and they were asked to speak to us a bit because of the improvement that they've seen in MSPB over the last year or so.
And sorry to meet Andy Wire is now online. Please go ahead, sir.
Yep. Can you guys hear me okay?
We can. Thanks, Andy.
All right. Yes. My name's Andy Wire. I oversee analytics for Ascension, Wisconsin. Just a little background there. Ascension, Wisconsin, a couple of our hospitals we were asked to present some information on. So, as I said, St. Elizabeth Hospital, which is in Appleton, and also St. Mary's Hospital, which is in Rhinelander, in the northern part of Wisconsin. Overall, Ascension, Wisconsin has 15 IPPS hospitals, 5 critical access hospitals, and one of those critical access hospitals is in Minnesota. And we've been formed by forming 3 Catholic entities together, so Ministry Healthcare, Columbia St. Mary's, and Wheaton, and over 100 clinics. So again, it's trying to pull this together, and as we look at things, we're trying to do more things as a system. Some of our strengths and weaknesses, I think, as we see this, is sometimes trying to do things as a system can be difficult. We have 7 different hospital EHR systems, and we have 5 different medical EHR systems, so sometimes even trying to pull data and pull things together can be difficult. But the 2 hospitals that we want to focus on, like I said, was St. Elizabeth and St. Mary's. So St. Mary's, they had an overall score of 0.83, and St. Elizabeth was 0.93. Both of these hospitals came from Ministry Healthcare, and we had a lot of these same programs that are going on that I'll kind of touch base on where we're at and where we've done these. The other thing I think is, as we usually look at these reports, one of the questions was, how do you use these reports? And we generally use reports as this, or value-based purchasing, or, the hospital readmission reduction program. We look at these, we try to see how all of our hospitals are doing across the system. We try to see if we have more current data to see if either the good performance or the bad performance kind of aligns with the data that we're seeing now, because as you know, these all have various lags in them. So trying to level the playing field there. We share all this information at our local boards and at our system boards on how we're doing with this information, and then kind of try to provide a little guidance and education on what these measures mean. So these types of programs are very helpful for us to better understand where all this information is coming from and how it can be useful. And as you look at this, as was also said, we've had some issues around some of the readmission. And readmission, it's in value-based purchasing, it's in the readmission reduction program. And readmission, because it ends up adding cost, ends up being part of the MSPB. So that was really one of our main focus areas that we have been working on. Around our readmission program, and and especially at within our legacy ministry healthcare, which both of these facilities fell under, we've had a long-running program that has been kind of rolling out in multiple phases. So our first phase was looking at our readmissions across heart failure. It's looking at information on, what medication they're coming in. So when patients were coming into the hospital who had been seen before, we're making sure that we get somebody from care management up there to make sure that when they get discharged, the discharge planning goes well, that we would call up the patients and make sure that if they had medication that they're supposed to be receiving, that they received the medication. We would make sure that if they had follow-up appointments, that those appointments were made and they followed up with their physician. We even made sure that at some of our hospitals that had an inpatient pharmacy, that they had the medication that they needed when they left the hospital, so that that didn't end up triggering any kind of readmission. And then as we started to roll out the phase and really start looking at this community program, we then started working with the clinics and making sure that when they're in the clinics that they're getting the current care, that if they have questions or concerns, they're not just showing up in the ED and then looking to get admitted, that they're working with their clinic to make sure to see if they need to be coming in for that. And then we've started reaching out and working with the skilled nursing facilities, the nursing homes, to make sure that if they're being either discharged to nursing home as part of a step before they end up going back home for any of their care, that everyone is clearly aware that's what we're working on doing. Or if they are from the nursing home, we want to make sure that the nursing home isn't too quick on sending patients back, that we're, again, working with the providers who are going out to the nursing homes to make sure that we have the patient in the right setting. We've been taking this program and then kind of expanding it and rolling it out in different phases. And as we started continuing to do this, the other phase now is we're looking to expand this across more than just heart failure. We're looking at COPD. We're looking at pneumonia. We're also looking at now, instead of focusing on the readmissions, we're looking at focusing on the admission, so trying to put more emphasis on the clinic side and making sure, again, that as patients are seen on the clinic, that we have the correct flow process going on there. And then as the previous person mentioned too, the clinical we call it clinical documentation specialist, just making sure that we have things coded correctly. So that was a program that we already had at Ministry Healthcare. And then about 2 years ago, kind of lose track of time sometimes, but about 18 months ago, 2 years ago, we started sharing that with the Columbia St. Mary's area, and then now we're starting to roll that out into the Wheaton area, and again, as we try to really provide the same level of care across all of our hospitals and facilities. So, it's not always about just staring and looking at the numbers. You clearly got to understand the numbers and where they're driving from, and then you got to look at the care processes that are happening behind those numbers, and then making sure that you're providing that consistent care across those measures. So those are some of the key areas that we've been working on across Central Wisconsin, specifically at St. Elizabeth Hospital and St. Mary's Hospital.
Wonderful. Thank you so much, Andy, for sharing. We really appreciate that. Recognizing that we only have a couple of minutes left, I did want to note that there was a question in the chat that I believe Eric will be able to address, and the question was, for patients that lived in skilled nursing facilities, how is the spend included or adjusted for in the pre- and post-index period?
All right, well, that's going to kind of go back to the information we presented in our first session, and it really just relates to those time periods that Sarah had shown. It's the claims that are happening from 3 days prior to that hospital admission through the 30 days post. And so for someone who has been staying in a skilled nursing facility for a long time period, it really kind of comes down to whether those claims are getting billed to Medicare or Medicaid. for this whole MSPB measure, we're only going to be looking at claims that are Medicare. So any claims that happen during those time periods that were billed to Medicare, that's what we'll be counting towards the cost. Now, as far as the adjustment, as we said, that's related to those 90 days before that episode. So if they were, say, staying in a nursing home for this whole time period, and if they had gotten seen some providers claims that were being billed to Medicare, whatever the diagnoses coded on those claims, that's when it will end up contributing. So I guess it really, if I'm understanding it correctly, it really goes down to what's being billed to Medicare versus Medicaid, or perhaps some other payer. And for this whole program, it's only going to be the Medicare.
Fee-for-service. Great. So we hope that helped answer your question, Casey. I did want to note that both my contact information and Eric's contact information are in the slides, and they're on the screen now. We did have a couple of other facilities that were queued up to share with us. Unfortunately, we've run out of time today, which is a good problem to have, that we had a lot to cover and a lot of engagement. We are interested in hearing from you as you complete the evaluation. If you are interested in furthering your knowledge around MSPB and possibly participating in maybe a small regional cohort that's focused on the topic, please let us know that either by sending us an email or by indicating it in the evaluation that you complete. And in that case, we'd ask that you let us know who you are in the evaluation so you can choose how you'd like to contact us. And we really do appreciate that feedback. We do use it to inform our future educational offerings. Again, if you have any questions and follow-up, please let us know, and a recording of today's event will be posted to the event page within a couple of weeks. Thank you all for joining us today. Thanks to our speakers and to those who shared on the call. We really appreciate your time and value the input that you were able to provide to all of us. Thanks, everyone.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.